Hello everyone from Zagreb, Croatia. We are broadcasting another one in the series of Neurosurgical Super Sundays. This is the third one. We have an esteemed panel here to hear two lectures from great professor Juha Hernesniemi and one lecture from Victor Hugo Perez from Mexico. We will start with Professor Hernesniemi, and before we start, we will ask the panelists to introduce themselves for a moment. Elena, do you hear us? Can you please tell us something about yourself?
Yes, now I can hear you. Can you hear me too?
Yes, we can hear you fine.
Oh, that's excellent. Hello, everybody. I'm so glad to be here with you to join you in the Hangout. I'm very honored to be talking to Professor Hernesniemi. We have here in Romania a club of students who are interested in neurosurgery, and we also use the videos of Professor Hernesniemi to learn new stuff. Some things about me: I'm a medical student. I'm in the 4th year, and this year I'm the vice president of the Walter Reed Dandy Neurosurgical Society. We like very much to share information and to help our colleagues ease the process of learning, because neurosurgery is not that easy and all the help needed is welcome.
Great, Elena. Thank you very much for this introduction. Professor Hernesniemi, we will kindly ask you to begin your presentation. Thank you very much.
Thank you very much. Hello, everybody, dear colleagues. So I will speak first on AVMs. Last time there was discussion about the AVM treatment, so I will now give more answers based on my experience and on a PowerPoint presentation. So I will go to my PowerPoint presentation. Yeah. Okay, you can hear me?
Yes, we can hear you. We just do not see anything yet on the screen.
See the PowerPoint presentation?
Not yet, unfortunately.
Can you see?
Not yet.
No?
Not yet. We just see a black screen. Oh, we can see the presentation now. Simple, fast, clean.
Okay,
Well,
okay. Then I can begin.
okay, you can begin, Professor.
Okay.
Thank you.
So I will speak about AVM treatment and how we do it. This presentation has not only been given in Adelaide, but in several places is crystallizing my experience on AVMs. So the principle of the treatment in all cases, whatever we are doing, or I have learned from my teachers, Dr. Drake and Fearless, is the simple, fast, clean, preserve normal anatomy. And this is how we should do surgery, and I follow this principle still after 44 years more than 44 years in neurosurgery. So to speak about cerebrovascular lesions, so I'm retired from Helsinki since 2+ years. 2015, I finished as a professor and chairman in Helsinki, and after that I have been working in Peru, Indonesia, and now in Nepal. So, but the main experience, my microsurgical experience, is coming from 2 centers in Finland, Kuopio, Eastern Finland, and then Helsinki since '97 as professor and chairman until 2015. And in these 2 centers, we have treated a big number of cerebrovascular lesions. So more than 17,000 aneurysm patients with more than 22,000 aneurysms. And we have very good databases on these cases, and so it means that we have also published a lot on based on this material. So besides that, we have also large number of cerebral AVMs and dural AV fistulas treated, and this is the number 1,500 patients, and I have personal experience on surgery, microsurgeries, more than 600 cases. So to see how whatever we are doing as a treatment, so we have to compare it with natural outcome, and Helsinki or Finland has been an ideal place to make follow-up studies, because Finland is like an island. There's a Russian border, peculiar language, and in the former times the people didn't move so much in the country, which has a very good social security, and it has made possible to follow up the patients, and there's also we know in which disease every Finnish person has died, so we can check the national registry here. So during the Second World War, when Finland was involved, so of course during this time no cerebral AVMs or aneurysms were treated, but they were by surgery, but they were treated by conservative means, and we have followed up these cases, diagnosed early, during and after the Second World War until nowadays, and so we have a long follow-up time. So in this series it is close to 17 years, and it has been updated now, so it is 10 years more to this follow-up years. But it means that there's a long follow-up time, more than 10,000 person years, and it is important that these studies are longitudinal, because if you take 10,000 patients and then follow up 1 year, then you have also the same number of person years, but because you follow up only 1 year, then you have no longitudinal follow-up, and actually nothing will happen in 1 year. But if you follow up that kind of long time, so many things happen in the disease progression. What was important in the Helsinki AVM database is that no patients were lost from follow-up, and this is unique material in that way. There's no other material where you could trace all the patients without losing anyone. And this careful follow-up is extremely important in clinical studies, because if you have lost the case and you find it later, so something special has happened in this patient, has a new bleeding, had new surgery, has residue, and so on. So you should find all the patients, because the most cases are the most important. And as I mentioned, in Finland there is a national cause of death registry, so we can find every patient's reason of death for every patient if the patient has died. So this means that because the world has changed, in former times only whales and birds could go around the world, but nowadays we are flying all over the world, and in this way the world has changed, the people are moving and changing their living places, so it is extremely difficult nowadays to follow up the patients. So the world has changed, and last time it was discussion about the Aruba study, so it is a small number of patients and followed up only short time, so we should trust on the largest series with complete follow-up. This is the Finnish study, and this study cannot be repeated for the reasons I mentioned, so these figures remain. So out of this study, for the cerebral AVMs, there's an overall rupture rate of 2.4% if you are managing the patient conservatively. And this figure is extremely important. So it is more than for unruptured aneurysm, 1.3% from uvula studies, so it is 2.4% a year. But the AVMs are not similar to each other. There are some special AVMs which are very nasty and prone to bleed, and these are the risk factors for the new rupture of the AVM. So if the AVM has ruptured previously, it is easy to understand that it may rupture again. If the AVM is located deep in the brain, it is more prone to rupture. If it is located infratentorially, it is more prone to rupture. And against older studies, the large size of the AVM, more than 5 centimeters, is important, increasing the possibility of the AVM to rupture or re-rupture. And this is easy to understand because in the large AVMs you have a high flow and you have also intradental aneurysms in these large AVMs. So this is maybe the most important slide in this presentation. So here you see the follow-ups of 3 different groups. You see the conservative group, green, partial occlusion of the AVM, lila, and then a total occlusion, whatever the means, mainly microsurgical occlusion, a few cases by stereotaxic gamma knife also. So you see that if the AVM is totally occluded, so the outcome is superior to partial or conservative occlusion or conservative treatment. So it is no doubt that whatever the means of the AVM occlusion are, so the long-term outcome is by far better than in conservative means, against what was said in Aruba. And this is also important because partial occlusion was beneficial only in those classical old cases where the flow was interrupted with a clip, like pericallous artery, distal AVMs, or MCA was occluded in large AVMs, and so on. So we found also that if you embolize partially occlude the AVM, so the risk of rupture is 3 times higher than in other AVMs. So our aim should always be that we occlude the AVM totally. So I speak now about high-grade AVMs. This means Petre-Martin classification 4 and 5. This is extremely difficult AVMs, and this outcome study we found that these difficult Petre-Martin grades are very prone to rupture and have poor outcomes. So you see that the ruptured AVMs have high number of new hemorrhages and also deaths in the follow-up. It means that we should take these difficult AVMs very seriously and try with all the means to treat these young patients. So this is a high-grade AVMs with ruptured AVMs, so natural outcome, you see that in 20 years, there's 62% risk for rupture, and now something happened, maybe.
Go back.
Okay. So, okay, this is the annual risk of ruptures here in the ruptured AVM, so it is high. So I speak about the microsurgery here. So there are some surgical tricks in cerebral AVMs, and I speak this from experience with more than 600 cases. So how to treat? I have no experience on radiosurgery. Just some patients have had radiosurgery, but I have been involved a lot with endovascular cases also. So importance in microsurgery is level of manual skills. So there are many different skills. So every surgeon has different level, but our aim should be to help our patients best to develop our skills as high as possible. And I call it international top specialist or black belt specialist. So like here, Robert Spessler in Helsinki 2009, or Tanikawa doing bypass surgery here in 2010 and in the following years. And can you see this one? Can you take it out? Other place. Okay, so level of manual skills depends mainly on number of repetitions and length of career. So it means that you have to spend 10,000 hours in training and then 10,000 days in operation room. Then you are at your best, and this happens to be around 50 years. So you can do the best surgery, but even if you are young, you can do good surgery. So what is important in microsurgery? It is good teamwork. No one is doing surgery alone. Especially important is the co-work between scrap nurse and operator, but also between anesthesia and other team members, usually 6 members of the team, at least. So this is a small package of AVM surgery. You have to have good attitude for surgery and proper training. Then when doing AVM surgery, head should be before cardiac level, and I prefer semi-sitting or sitting position. In superficial AVMs, you should make a good flap to see the surrounding and AVM vessels, and to separate the AVM from the brain substance, you can use water dissection, which I have shown last time. And something that changes very much are temporary clips on large feeding arteries. And you should save the end passage arteries, not to destroy the brain distal to the AVM. And in the beginning, you should use first very sharp dissection, and then in the deep, very nasty small vessels, you should do dirty coagulation, that is, coagulate the small vessel with some brain substance. So, because in these small vessels, there is nearly no wall. And when you have finished the AVM resection, so if there is some bleeding from the bed, this means residual AVM, you should take very good care of that, because even the smallest residual can bleed and bleed even fatally. And in the large, difficult AVMs, as I was speaking, especially 4 and Martin 4 and 5, so you should use embolization helping you. So I have used since 8 years under very high magnification to extirpate these AVMs, and in all surgery, in tumor surgery, animal surgery, I push the button of the microscope for the highest magnification, and this is usually this one. It is difficult to operate under high magnification because your hands are difficult to bring back to the operative area, one of the tricks is never take both hands away from the operation area. So one instrument always in place, and this means that you can come back. And one of the important things in the AVM surgery, because these are one of the most difficult lesions to operate on, you have to have peace in mind and concentrate for the operation. You should not fight with your partner, girlfriend, wife, husband, or with your team or administration or whatever. You should have really concentrate for the surgery and not take it, have other thoughts during the surgery. So peace in mind is extremely important. And if you say that let's try to take the AVM out, then the patient is already invalidized or dead because your attitude is wrong. You have to be 110% sure that you can take the AVM out, and you have to have cuts or tissue to take it out. So, like here in this case, this is number 3 in my series of more than 600 AVMs. So I operated January 27, 1982. I remember it was extremely cold day in eastern Finland, and in 10 hours operation, I took this giant AVM out, temporal AVM out, and what I can say afterwards, even now it would be difficult. Nowadays it would be embolized, that time not. Embolized preoperatively, that time not. But it was possible to take it out because I had read my books, made my homeworks, seen the giants to do AVM surgery, and I had the attitude to fight. I mentioned already the word sisu, which means cut in English. So you should save and passage arteries, you should put temporary clips on the feeders. Here is a picture or video, but it's not running, and it's not running. So temporary clips are on pericallosal and callosal marginal arteries, and below that or distal that is the AVM, and should giving small feeders to AVM, both callosal marginal and pericallosal artery, and we should coagulate them all and then cut and save the passage arteries. And here is the dirty coagulation when we have taken nearly the whole AVM out, excluded it from flow. So very small arteries take the strong flow, and if they rupture, they bleed, and difficult to stop these bleedings because of the wall is so thin. So to help that, so dirty coagulation. So doing the large AVMs in the beginning, you have the feeling that you are the greatest neurosurgeon in the world, but when you come to these small vessels, then later, so you have the feeling that you are the worst neurosurgeon in the world because they are really very difficult to stop. So good bipolar coagulation important. Here one example in pictures, regular AVM, temporal AVM, and the tricks used here are water dissection, temporary clips on large arteries, saving and passage arteries, and as mentioned, sharp dissection, dirty coagulation, and taking the residual if they are out. So this is the AVM, temporal AVM, and this is postoperative. Postoperative, you should always do DSA to see that the whole AVM is gone. So once more to come into the speaking about the small arteries. So big arteries are not so important, but the small arteries deep at the base of the AVM, especially paraventricular, they are very difficult to stop or to exclude from the flow in microsurgery, and these are the most dangerous vessels with microsurgical means. So bipolar coagulation is the most important instrument in microsurgery, and this slide I have shown many times. If you don't believe in God, so believe in bipolar, because with bipolar you can coagulate every vessel and you can stop all the bleeding. So don't get desperate, don't tamponade, just coagulate, and then you will have a good result. And once more, this is the dirty coagulation. So you should, the scrub nurse should clean all the time the bipolar forceps and have many of them and change them all the time and very fast. So then you can do fast surgery without getting tired. So we are coming once more back. I was missing this part of treatment in high-grade AVMs. So I have done around, with microsurgery, around 100 AVMs. This is a series until 2009. So you see that there are 60 patients, grade 4 and 5. And you see that there are also deaths and severe disability. But as compared to the natural outcome, so these results still are better. And you have to see that here are something like this. This is a male, 35 years old, had epilepsy, and came this monstrous AVM to us, and had never bleeding. He was working, and we made angios. You see the huge AVM with huge flow, and we began to just embolize a little bit. We tried to embolize a little bit, and then send the patient home to come 3 weeks later for more serious stepwise embolization. But what happened? The patient died 2 weeks after discharge in new bleeding because of this huge AVM. We didn't realize that it has ruptured. And my experience is that if the patient has epileptic fit, so it means that the AVM has ruptured, because in surgery in 2/3 we find hemosiderin in so-called unruptured AVMs. So to treat that kind of AVMs, you have to concentrate all of your power. This means that kind of AVM needs preoperative embolization and then the radical surgery to stop possibility of rebleeding. So here's one example. This is a Russian patient, 28 years old, had this parietal AVM, motor area AVM. Dr. Drake, my teacher, called them impractical, but this AVM was embolized 6 times with Onyx by Professor Moret in Paris, and this way it was changed practical AVM with Dr. Drake's words, and this last feeders were then in the link course occluded in a short operation, and this is the opening, and we see that there's a little flow, and this is after operation. The onyx cast remained in this case in the place, but there is no early filling of the vein, because the small arteries feeding the AVM still, they were taken under microscope with bipolar coagulation and cut. So using the embolization, there are also complications. This is very feared, and complications occur in different frequency with embolization. Of course, there are also different hands and experience in embolization. So, but even in the most skillful hands, So complications happen, and I saw 3 very complicated causes in these AVMs. So here we have a male, 57 years old, and had one bleeding from the AVM, not from the large aneurysms. Several aneurysms were there, and for reasons I don't know exactly, Professor Boré asked to operate on first the aneurysm and after that embolization. And these aneurysms were operated on, and after that AVM was embolized several times. And the last time when it was thought, it is now everything with embolization has been done, and the patient was going to be sent home to come for surgery later. So what happened with the patient? 3rd day after embolization, he was found deeply unconscious in restroom, pupil dilated. The patient went directly to operation room, and the hematoma was taken out, and the AVM also. But this means usually in AVMs, if you have post-embolization or post-operative hematoma, the patient is severely invalidized, and this is the post-operative CT scan of the patient. You see that there's some edema, AVM, and hematoma has been taken out, and this meant that the patient was not able to take care after recovery of himself and remained in a rehabilitation center first, and then in a house needing support all the time. Another case, very dramatic case, a patient, a 33 years old female, had headaches and this large AVM in the left temporal lobe, getting feeders from posterior circulation and middle cerebral artery, and this AVM was first onyx embolized, the lower part right. You see the onyx cast, a lot of onyx inside the AVM, and what happened during the AVM embolization, it was suddenly we saw that the slowing in the circulation, and we saw that in angio contrast was coming out. So it meant that the AVM ruptured during the embolization, and there was also slowing in the draining veins. So we went directly. This is once more the onyx cast. And we went directly into the operation room and made the big frontotemporal flap and took the AVM out. It looked that this has a lot of occlusion, but it was not so during the operation. So some of the arteries occluded by the onyx, they are partially open, and so there was high flow also there. So, but anyhow, the AVM was taken out, and post-operative pictures look beautiful. AVM taken out, CT, and here angiography. Beautiful. Total extirpation of the AVM, but even the patient was conscious and doing so physical recovery well. So first she was confused, and then became extremely depressive after the treatment. So she lost vision in the left eye because a small drop of onyx went inside ophthalmic artery, and but the depression that lasted 3-4 years was the worst thing. So she wrote to Helsinki from her home country every week, long emails telling that she cannot live anymore, and so was very suicidal and very difficult, and it was very heavy burden to answer all the emails and the correspondence, and but now after 10 years, so I got an email that she's doing well and is now happy with her life. But it shows that not only the pictures are important to prove the outcome, but also the clinical outcome is extremely important. This is the neurosurgeon who has to be the medical doctor to take care of the patient. This is his or her duty to do this work, and this is extremely important and also very heavy. And then this is not this is a difficult case also because we failed initially in the treatment. So 2002, this 9-year-old girl came with mild left hemiparesis. She has always been a little bit clumsy, and we found this huge central AVM which had stereotaxic irradiation just to do something. That time no embolization was possible, and even now it would be difficult to embolize this one. And so we didn't give much hope for the radiotherapy, but what happened, the patient was doing well until at the age of 18 years, she got headaches and sudden left hemiparesis and lost consciousness. And she came to us with this picture. This is CT. You see a deep central hematoma, and in CT angio you see a terrible AVM, at least as big as in the angio. DSA angio earlier, so you see completely impossible looking AVM. So the situation was that she had a dilated pupil and was deteriorating, so I went to operation room with her, made a right-sided frontotemporal flap, and went to take the intracerebral hematoma out, and it was bleeding when opening the Sylvian fissure. It was bleeding like hell. It looked that all the blood from Helsinki was coming out, that I could stop the bleeding. Even I have thought I'm losing the patient on the table, but I could stop with bipolar coagulation and with some clips, and some of the feeders were clipped. So happy for the outcome that the patient, we could stop the bleeding, take the hematoma out. But post-operative, this is the operation video not running here. So, but anyhow, I made 3 operations on her, because after first operation she dilated also the other side pupil, left side pupil, and CT showed that the hematoma was even bigger. So I went the next day as emergency inside from the same flap, right-sided flap, and occluded all the 3 arteries, M1, A1 and P2 with temporary clips, and took the AVM out. It has 2 times still some residual, and after 4 operations it was totally occluded, the AVM, and this shows the control angiograms. And total extirpation of the AVM, patient regained conscious, but of course had left hemiparesis because of the deep location, deep site of the AVM. Nowadays, she is doing well, considering the difficult situation. She had dilated pupils, but both sides. So she's living alone, studying, and having left arm totally paralyzed, but she's able to walk and use the left arm to carry her back and so on. But she cannot move the fingers, and so it is flexed in contracture and spastic. So after thinking back and speaking about this experience about the high-grade difficult special Martin grade 4 and 5 AVMs, I think they should be treated because they are young patients and they have long lifetime ahead. So they should at least treat it when ruptured. And when speaking about unruptured AVMs, as the AVM with monstrous AVM in the young patient with epileptic fit showed, we never know exactly when the AVM has ruptured. My experience is that if the patient has epileptic fit, then the AVM has ruptured. So anyhow, these difficult AVMs should be treated and by experienced teams, and also those which we consider unruptured, they should be treated according to my nowadays thinking. So we should not turn our back to these monstrous AVMs because they are located in the brains of young patients and are sooner or later invalidizing or killing them. You have to speak seriously about the treatment with the patient and family and take an active attitude in these cases to give them the best outcome. One of the things when we speak about AVMs, there are different series where you say that so many percent were totally occluded. So if you have 1,000 cerebral AVM patients, so if you take for your treatment 500 and exclude 500 patients, so out of these 500 patients treated, you totally occlude 300%. Then your success rate is 30%, not 60%, like in some series is claimed. So it is important to know that. And this is a very nice meta-analysis by a Chinese neurosurgeon about total occlusion rate in many series. So with microsurgery, you can occlude nearly all the AVMs. With radiosurgery, more than 1/3, and with embolization, only 1/8, 13% in all collected series. So, and once more, the nice sentence of Dr. Drake. So if we have complications, so we should analyze them very carefully so that we are not making the same errors. So we should benefit from the complications to do in future better, because seldom we get the second chance in operation room. One of the important things is that the memory is very short. Memory is very short. It is seldom inactive by active neurosurgeon. Surgeons more than 3 months, but with databases we can see every case where in a few seconds what kind of complication you had in your series, and what, of course, also what kind of beautiful outcome in your series. So I mentioned important to be a medical doctor. Here is Dr. Drake. He had the abilities of a medical doctor, an excellent neurosurgeon. That one of important thing in this trias is also to be a good human being, and this is certainly one of the most difficult things. So this is a medical doctor, important in treating desperate patients in desperate state. Here you see the medical doctor. Doctor taking care of a sick girl, and you see that the father is standing there and he has not many means to help. The doctor has not many means to help the patient, but he's there and taking care of the patient and family and supporting the family. So in the same way we should do also in taking care of the critical ill patient. So thank you. I think this is enough for the AVMs. Maybe we can discuss, and then I can show some videos on pineal, on colloid cyst and pineal tumors.
Thank you very much, Professor. I would just like to ask the panelists to introduce themselves, because we have lots of new panelists coming in during your presentation. So, Dr. Hadi, if you are here, can you please introduce yourself? Dr. Hadi, are you here, perhaps? I'm not sure they can hear, but
I cannot
this is the opportunity for you on the panel to introduce yourself. Here is Dr. Hadi, yes. Hello. Yes, we are sorry, we can hear you. You have some trouble with the phones. Hello. Now we can hear you, yes. Yes, hello. Yes. It's still a bit, you can still hear some crackles in the sound, but... Yes, thank you. Thank you. It is okay. Thank you. Dr. Lumigano, are you here? Maybe you could introduce yourself.
Good afternoon with everybody. I'm Carlos Yumiguano. I'm a new surgeon, and it's really good for me that to hear the talking about the EVM management for Dr. Hernesniemi.
Thank you very much for your introduction. Dr. Nguyen, are you here maybe? Can you introduce yourself? Welcome.
Yes, yes. I'm Nguyen Thich from Hanoi, Vietnam. Welcome, please welcome. This is my chance to participate this video call the second time. Thank you.
Thank you very much. And we have here Dr. Rakesh from India also. Hello, Rakesh. You have a good looking background.
Yeah,
hello.
Thank you. Hello. It is my great pleasure to be part of a presentation from the great neurosurgeon. Thank you so much. I am Dr. Rakesh AV. I am a neurosurgery resident from India. Thank you so much.
Yes, we have here Dr. Hoz also, who was recently on a fellowship in Japan. And he has some troubles with connection, so he asked me to introduce himself. He's a neurosurgeon from Iraq, also who trained under Dr. Hadi, who is also here on the panel, and is currently leading the Hoz Neurosurgical Lab. And we have here Dr. Sanji. If you are here, you are welcome to also. Hello. Please introduce yourself if you can. You will have to unmute yourself. Dr. Sanji? Yes, okay, maybe he cannot hear us. I would like to open the discussion now. What's going on? I would like to open the discussion now. So if you have any questions, please feel free to ask.
I would like to ask, if I may, after congratulating for such a great presentation, what was the minimum age of the patients with
usually the AVM patients are younger than cerebral aneurysm patients, so the presentation is lower than in cerebral aneurysms. But of course, if you diagnose AVMs in very old patients, so let's say 70 years, in my estimate, so it should be act completely different than in a patient who is 15 or 10 years old or 20 years old, because the length of time or the time you have left in your life or in future, so this is the most important. So in 20 years old patient, you have certainly 50, 60 years of life left, but in 70 years, completely different. So you have to calculate the natural risk according to age, and discuss with the patient and the family about that. Of course, the risk of treatment are also by far higher in old patients than in young patients.
And also, I would like to ask, what was the youngest patient with AVM that you actually operated on?
1 month. 1 month. I remember very well. It was very difficult not to suction prevent me suctioning the brain, because it was so baby brain, so it was very difficult. It was temporal AVM that ruptured, 1 month old.
Yes, thank you. We have a question from Dr. Hadi. From Dr. Hadi also, who can you try to asking it, Dr. Hadi? Here. Please put your microphone close. Unfortunately, we cannot hear you like this. There is lots of... maybe if you can... I'm sorry, Dr. Hadi, maybe if you can type in the question, I will read it for you, okay? Maybe it's better this way, because there is lots of crackles. We have a question from Samer Hoz here. What is your opinion about the supplementary grading system that uses 6 factors instead of 3 factors of the Spätzler grading for Professor Hernesniemi? Can you see the question?
This, of course, I'm maybe too simple to use it, but I know in the last publications from Helsinki AVM it has been used, but I don't think it is for me. It is not extremely important. So I am used to use special marking grading, and I don't understand or I understand that there is a part of the systems, but I'm not. I don't think it should be not so important that you take so much care of the grading system. It's more important to take good care of the patients. I made also I published also 1989 a grading system. It is very similar to the new grading system that is published by Lotto. So it is all same ideas are coming and going. So.
Yes, we have another question from. We have a comment from Dr. Hoz on your answer. Big difference is the nidus very compact or diffuse. Is it important to consider? The big difference is whether the nidus.
Of course. This is very important. This is very important. Also, of course, for embolization and for the nature of the AVM. So, you have to manage. You cannot change the AVM. Before the operation, you can assess, and you have to be careful in assessing the AVM. But it is, of course, big difference. Also for endovascular surgery, it is big difference if you embolize a compact or diffuse AVM.
We also have a question from Dr. Hadi. What is the best timing of preoperative embolization? Is it better to do it like the day before surgery or a few weeks before?
I showed the examples where we have difficulties. So there was one intraoperative rupture in the young lady, 33 years old, and then we had in the older patient, we had 3 days after embolization, huge hematoma that destroyed the patient. So I think nowadays the attitude is that if you make radical or very heavy embolization, you should operate within same day or next day. So most safe is to operate the same day, because onyx is like an animal. It is living inside the AVM, and there will be more thrombosis than during the DSA. There will be in the next coming hours. There will be more thrombosis, and so it is very difficult to assess. One of the most important things is that when you are doing the embolization, so you should not get what I call onyx drunk, because then when you get you try to push onyx more and more, and then you want to have the AVM totally embolized, and then you suddenly have occluded or slowed down the draining vein, and then the AVM will explode, like I showed in these cases. So there are 3 complications in onyx embolization, and 3 serious complications. This most serious is the postoperative hematoma, intraoperative hematoma, postoperative, intraoperative bleeding first, postoperative hematoma within 3 days, and then you have late hematomas. They usually are not embolizing the patient, but it can happen even after several weeks. So timing should be as soon as possible.
Yes, we have a question from Dr. Yumigano. Can you try asking it? Or maybe, yes, please try asking it, Dr. Yumigano. I think your connection is quite good.
Hello. My question is about at this time the management of the AVM is more different in some centers. What do you think about the effectiveness of the treatment? Just AVM is treated just with surgery, or surgery plus gamma knife, or embolization and gamma knife? What's about the results? What do you think about that?
I showed the slide, the meta-analysis. So with microsurgery, you can occlude nearly all AVMs. With endovascular, 13%, and with gamma knife, 38%. This is the meta-analysis, all collected series all around the world. So I cannot disagree with this meta-analysis. So this is also my experience.
Thank you. Thank you. But I think it's so many centers. It's taken difference in the management. Maybe so many great groups of the neurosurgeons who or radiologic interventionists who have decided that in some cases treatment will be better if they are using just embolization and some kinds of or baby shots. I think I agree with you that the meta-analysis in the world is doing by the biggest centers, but in my opinion, the correct treatment or the more effective treatment of the ME will be surgery, and after that we can use maybe if they are needed some kinds of radiotherapy if they are something remaining of the AVM.
Of course, we need radiotherapy. I showed one slide. We need all the tools, even praying, concentration for the operation. So we need all the tools to manage difficult AVMs. And as I mentioned, there are different hands and different centers. So I'm telling only about my experience. I have done these discussions many times, and you cannot influence the level of the centers treating the AVMs. You cannot influence the patients who are coming to the AVM treatment, so you can only see the reports. One of the important things is that published cases are always the best series. So you are not usually publishing worst cases. So they are selected cases what you get in the meta-analysis, so selected series. So the reality might be certainly worse than in these meta-analysis figures. So anyhow, this shows that with microsurgery you can occlude nearly all the AVM. So this is my experience.
Okay, we also have one more question for now from Dr. Hoz. Again, in your experience, Professor, did you face a lot of staged surgery because of the angry lesion?
No. I in the 80s, before the embolization came and before the temporary clips on the feeding arteries, we sometimes did stage surgery, but I think this is also very difficult. So because if you go for an AVM, and if you have bleeding, you cannot tamponate or stop the bleeding. So I have always aimed when I do surgery for the total occlusion, total extirpation of the AVM.
Yes, thank you. We have another presentation now from Professor Hernesniemi, so we can continue now if you're ready, Professor.
I'm ready. So I will. I operated yesterday one colloid cyst case here in Nobel Institute for Neurosciences, and I will. That's why I show some videos on the third ventricle colloid cyst, and also maybe if we have time, some of the spinal tumor surgery. So
we have all the time. Yeah, you can take as much as you want. Thank you.
We take the videos now. So yesterday I operated a young patient, 30 years old lady. Take this one, colloid cyst. Let's take this one first. So it was a 30 years old lady yesterday coming with headaches and a little bit drowsy, and she had a big colloid cyst, bigger than this one. Here, this is from Helsinki series, so you see a colloid cyst. They are called foramen Monroe colloid cysts, but I have called them third ventricle colloid cysts. So I have done between 150 or 200 of them, and I have also published my series on this approach. So this is the transcallosal approach to this lesion. So here the patient has head high, and then we make a flap where the coronary suture should be in the posterior part of the opening, and the opening should be the midline and then large enough. So because there are important draining veins, and like yesterday there was a big venous lake in the middle of the craniotomy, so I had to go in front of it. And here, carefully under microscope, opening the dura, not to disturb any draining veins. Maybe I lost here a small one. I think that I had lost here a small one, yeah. But have to look carefully on the dura to see the draining veins and not to destroy them, because they might be extremely important. So here I'm losing something, one small draining vein, but it should not be so bad. It's impossible here to open totally. You see that I open only very little of the dura to save big draining veins in front of the dural opening. So we come to the midline, and the dural opening is very short, and there's also one draining vein here. So very difficult to come to the interhemispheric fissure here. You see that the head is high because the vein is pulsating, but then collapsing sometimes. So this is one of the important things, and you have to take a look carefully where you are going, so that you can come through corpus callosum incision to the foramen Monroe without. This is small dural schizo, but under high magnification it is very big. And then you have to have dura. So with the sutures, hold with sutures, so that that you come to the interhemispheric fissure without disturbing the brain. And here, still under microscope, dural bleedings are stopped, and then arachnoid fibers are cut, and then we see the falx here, and this draining vein should be preserved, because it is the old classical saying is that you can in the frontal you can cut the draining veins, but it is not so, because if there is an anomaly of the venous flow, then patient will have a hemorrhagic infarction and eventually even die for that. Then we come down, and one of the most important things is to go between both gyrus cinguli to the corpus callosum. And how to know what is corpus callosum? Corpus callosum is white, and this is extremely important because gyrus cinguli is gray. And if you make a mistake, so you will destroy the patient. Here the forceps is going through corpus callosum, right pericallosal artery on the retracted with the bipolar forceps, and the incision is short, so 10 to 15 millimeters, and then we have to take a look carefully that we come to foramen Monroe. And foramen Monroe we will identify with plexus chorioideus, and this plexus chorioideus might obstruct the view to colloid cyst, so you don't see anything in the beginning. Even in the pictures you see a rather large colloid cyst. And I'm usually nowadays no more using retractors. I retract with my bipolar forceps and sucker. An important thing here is that never take both instruments at the same time out, so leave always the other instrument there. Now, below the plexus chorioideus, you see that the gray-blue color is the wall of the colloid cyst, so it is plexus is coagulated and sifted, and we will slowly come to see colloid cyst better. You should take care of the veins here. Now, one of the important things is, in my experience of so many cases, that these colloid cysts are actually located inside the third ventricle, and only the upper part is at the foramen Monroe. So this is important in the surgery of them. This seems to be rather deep located, and then we have to have a hole in the colloid cyst so we can suck the colloid out, and then we have the wall of the cyst to deal with, and this cyst has vascularization from tela chorioidea. There are usually two small arteries and one or two veins, attached to telachoridea, and here we are coming to the posterior part of the tumor. You see under high magnification those feeding arteries, they are coagulated and cut. And then partially emptied colloid cyst is coming out. Some of the colloid cyst, the colloid is amorphous, so cannot be sucked out, and so here one more connection is taken, one more small arterial feeder, and now the colloid cyst is coming out. And still coagulating the attachment to the telachoridea, and then cutting. Now taking resection, and then most important part is extremely good hemostasis. So if you have a bleeding, it is usually coming from the posterior part, here from telachoridea, and you have to take very good care, and you have to have a clean rinsing water coming out and fill the cavity. And here we had difficulty, so I put the hemostat there. You may say that it's floating there, but usually this hemostat is attached very heavily, so it is not floating out there. Then a lot of rinsing with water until it is clean. You should not close if there is even the smallest bleeding. And then some hemostatic and glue is put in the corpus callosum incision. This is postoperative picture, colloid cyst taken out, and maybe I show another video. Let's take. It doesn't matter, so let's take this one. Another editor, this is a Thai neurosurgeon. This is extremely small. We go out. Why? The patient, it was growing, so we take, okay, maybe it shows good also the surgical steps here. It was a small one, so the indication for surgery has been that the colloid cyst should be 1 centimeter or more, and the patient should be symptomatic. Why this has been selected, the 1 centimeter limit, is that I have seen in Eastern Finland, so 2 cases which had lumbar function, CSF drainage, and they both became unconscious and both had very small colloid cyst. So we selected this one as a lower limit for the surgery. And here again, opening the dura, and here again, very little opening because in the posterior part of the area there's draining veins, and so we open only a small part. And then going inside in the hemispheric fissure, here not so difficult draining veins than in the former case. And then again, going between gyrus cinguli and identification of the corpus callosum and the trajectory to the lesion is extremely important. So you should take a look on the patient when you position the patient so that you know which direction you are going. And that's why I think it's very important that the operator is positioning the patient and knows exactly the head position. Otherwise, you will go too much anterior or too much posterior, and then you will have big difficulties in finding the lesion. So now coming down, and this we see the two pericallous arteries first, and then extending the opening, and then we should see the white of the corpus callosum. Then when we see corpus callosum and we are sure about that, then we are safe. The patient is safe. Suctioning CSF out. We are still looking at the gyrus cinguli, I think, yeah. That shows how difficult it is. Sometimes the gyrus cinguli are very attached. If the patient has a lot of hydrocephalus, then also the gyrus cinguli are not so high. But now we can see. Now we see that these are two pericallous arteries, and between them we see the white color of the corpus callosum, and then now we are coming to our goal. Yeah. See, completely different colors. This is white, really white. We retract the right pericallous artery laterally. We should not go lateral to the pericallous artery because there are small feeders to the gyrus cinguli from pericallous artery, and during the surgery you may break them, and there will be heavy intraoperative bleeding, disturbing the view. So small cotton is put on the pericallous artery, and then the artery is retracted to laterally, and then we are searching for a good place for our corpus callosum incision. I usually push one cotton anterior and one cotton posterior in the hemispheric fissure, and it's important to have the incision laterally. Then we come to the third ventricle. Otherwise, you go in the midline and you may destroy the fornix. Then you are happy when you come in the lateral ventricle. And now we have disturbing bleeding here, venous bleeding. Must come from the corpus callosum incision somewhere. And now we look inside the lateral ventricle, and we should find the Foramen Monro venous bleeding coming from the corpus callosum incision still continues. We should do something for that. Coagulate here. Yeah. It stopped. And now we are inside the lateral ventricle, and we can see the plexus choroideus, and we will see the small colloid cyst below the plexus choroideus. And you see that we see the tumor. It is low inside the third ventricle. And now open the colloid cyst, and you see that there's some part is amorph, it's taken out. And then we have, I think, a capsule of the tumor. And here we coagulate the feeders to the capsule and draw the capsule out. There's some, this is not fluid in this amorph colloid cyst. So now with the tumor forceps, I take out and use a hook to dislocate higher up. Hooks are dangerous instruments, so I don't like to use them, but sometimes you have to use. Why hooks are dangerous? Because you may make an error and you draw it out in the wrong angle, and then you have a lesion. So now the tumor forceps is grasping the remnants of the colloid cyst. My hand is shadowing here. Dissecting with the sucker. And now the tumor is coming out, the remnant of the tumor, main part of the tumor. So now we have the good view and clear water, rinsing water. And after that we can close. So we should not close before we have absolutely sure good hemostasis, and these are post-operative pictures and good outcome of the patient. So maybe I show one more. This is not colloid cyst, but this is a astrocytoma. This will be the last video I will show this time. Next time I can show the pineal tumor videos. Maybe next time I can speak about pineal tumors. So here is a rather similar looking tumor, but it's more posteriorly located, and but this shows the approach, and here it is. I think it's left-sided because the tumor was more on the left side. Usually I go from the right side. Not big difference here. It seems that the patient has been operated on earlier. It's old flap there. Then I opened the dura always on the microscope to preserve the draining veins. And here it is especially difficult because the patient had an earlier operation, so there is scarring, and in reoperations I always open under microscope. So in the hemispheric approach, and then the white of the corpus callosum is coming. So you see the white color. This is corpus callosum. Pericallosal artery, and then retracting pericallosal artery laterally, we go inside the lateral ventricle, and then we'll come to the foramen Monroe. There's a thalamus straight vein, should be preserved always. I'm dissecting here, and now it is not so obvious that we will find the tumor so easily like in the pictures. But here the tumor is coming. So, gray color of the tumor, it was benign astrocytoma. And sucking the tumor away, preserving the vessels. The basilar artery can be seen here, because we are inside the third ventricle. And then hemostasis, and as in the former picture, operation, so closing of the corpus callosum incision and then closing everything under microscope until the skin. So I think this is all now. Now here my technicians are nervous because they have a New Year party beginning 1 hour ago. So I think we will stop now. So we stop.
Thank you very much.
Thank you very much. Thank you very much.
Well, now just I would like to allow our new members of the panel to introduce themselves. We have here Dr. Armando. Do you hear me?
Yeah. Hello. Thank you, Professor, for the lesson. I'm a student from Bolivia. It's a really good experience. Learn from the best. Thank you.
Thank you very much, Armando. And we also have Dr. Tan here. We also have some questions from the panelists. So we will ask you, Professor Hernesniemi, just to answer a few questions more. Dr. Tan, welcome. Can you introduce yourself, please? It seems that Dr. Tan is off the air. We have a question here from Dr. Hos. The question is, let me just see. How frequently do you use external ventricular drain?
Some of the patients had preoperative shunting. Myself, I have not used the training. I have not left training. I have to have hemostasis. But yesterday, because of the pressure from anesthetic side, I left the drain. So you should never say I'm never using. So usually I'm not using any drainage, but go directly to the ventricular system I can remember a couple of cases where there was so severe hydrocephalus, I had to tap the lateral ventricle with a needle. But this is seldom. This is seldom. If you have good anesthesia and the head is high, so you don't need any ventricular drainage during the operation or afterwards.
Okay.
Afterwards, if you have good anesthesia.
Okay, we also have a question from Dr. Hadi. The question is, your opinion about endoscopic excision of colloid cysts?
It is certainly nice techniques. What I have felt in endoscopic operations, your instruments still are not as good as in microsurgery. So this is when you, I mean, in going intracerebral. So of course, when you go, you can do it through 2 channels, like going. Then it is wonderful techniques, but here, for example, for colloid cysts, you are going usually through 1 channel, and then the instruments are not as effective as in open microsurgery. So, but I think you should use those techniques which you can do well. So if you have used one technique, so do it. Don't say change always, because you learn the anatomy and the drawbacks of this route. So I don't fight a lot. One thing I know that, for example, that if you do stereotactic aspiration in these cases, it's not good. You cannot take the whole colloid cyst out, because you have to coagulate the feeders attached to therachorioidae. This is seldom possible except by open microsurgery. So the endoscopic surgery has beautiful results. And why not? But in my hands, I have done in 90s endoscopic surgery, so I didn't feel that the instruments are good, so I gave it up. But maybe I should have continued.
Thank you very much, Professor Hernesniemi. We just have an announcement from Dr. Bennett that Dr. Luis Borba is also watching this presentation, and he would like to greet you through Dr. Bennett and through the messages. So he was very amazed by your presentation.
Okay, thank you, everyone.
Thank you for your
Happy New Year. Next year again. All the best wishes for New Year from all of us here in Nobel Institute for Neuroscience.
Yes, thank you very much for your time. We will also have one more presentation given by Dr. Perez from Mexico City. And we would like to invite all the panel to stay here for a few more minutes for the 3rd presentation to begin. And Happy New Year to everyone.
Again, thank you. Bye-bye.
Thank you, Professor, so much for your time and knowledge. So I will check, is Dr. Perez coming in? This part will be edited out afterwards, so feel free to talk if you would like to, because we will have this part cut off from the whole presentation.
Hi, Slaven. The first the presentation from Dr. Ipe is over.
Yeah, unfortunately, Dr. Ipe couldn't present today, so Professor Hernesniemi did 2 presentations. You know, so that was the change in the program. But yeah, it went well, I think. We'll just see. I'm just trying to see from Dr. Bennett when is Dr. Victor coming, because he said that Dr. Victor is prepared for the lecture. So
Okay.
yes. But yeah, it went well, I think. Hello, Dr. Bennett. I'm just trying to see from Dr. Bennett.
Yeah.
When
Can you hear me, Slaven? Can you hear me, Slaven?
I can, yeah.
Yes, we can hear you.
Just hear some noise from your background, like YouTube video or something. So
Okay.
okay,
I'll turn it off. Okay.
fine.
Okay. Let me turn this off. Hold on.
Yeah, welcome.
You're doing great, Slaven, and welcome everybody. And Victor will be coming in shortly.
Wonderful.
Yeah, it's me. It's me. Let me get off this thing.
Okay. I'll turn it off. Fine.
Yeah, I got it off. Can you hear me okay now?
Yeah. Now it's fine. Dr. Hadi,
Okay,
we can
good.
check your sound also while we're waiting.
Okay. Well, we'll get better at this tech, muting and things like that. But let me jump off and try to get Victor in, okay?
Okay. We'll stay here.
Okay. Yeah.
Dr. Mar, I would like to try your audio now, if you can, just to see what was the trouble. If you can unmute, maybe. I'm very sorry that you cannot talk. Yes, for now, I cannot hear anything from you. Okay, Victor, Dr. Victor is coming in anytime now. Okay, here is Dr. Victor.
Hello, how are you?
Our star of the day. Hello, doctor.
Hello, Dr.
Nice
Victor.
to see you.
Very nice to see you. How are you today? It's almost New Year.
Yes, we
wish you
are
all a very happy
fine.
New Year.
Thank you. We wish you a happy new year, and we have some of esteemed panelists here. If you are ready to start, we can then just announce the panel, and we are ready to go. Okay.
Yes, I'm ready.
Okay. Let me then just. We are already live, so I will just go on and try to introduce the panel. Dr. Hadi is here, but I'm not sure if he can hear us now. If you can, Dr. Hadi, could you please introduce yourself? If not, I will introduce Dr. Hadi. He's a neurosurgeon from Iraq who is a senior and a training neurosurgeon there. I mean, who is training other neurosurgeons. So really a great addition to our panelists. We also have here Armando from, can you please introduce yourself?
Hi everyone, I'm Armando Soriano. I'm from Cochabamba, Bolivia. I'm a student of medicine of 5th year, and I love neurology and neuroscience and neurosurgery, and thank you for these lectures.
Hope to see you there in Cochabamba next year.
Oh, you will be.
Yeah, there will be a meeting, the Latin American Congress of Neurological Surgeons.
Oh.
Yeah, in Cochabamba next year. I think it's going to be held in September or October. Yeah, I'll see you there.
I will go. I will go.
Yeah.
That is a great announcement to make. So thank you, Dr. Perez, for mentioning it. Also, we have here Dr. Nguyen from, I hope I pronounce it right, from Vietnam. Can you please introduce yourself?
Yes, hello. I'm Dr. Nguyen Dic from Hanoi, Vietnam. I'm a neurosurgeon. Yes, it's second time for assist this video call, and my pleasure. Thank you.
Nice to meet you in this conference.
Nice to meet you.
And we also have our longtime favorite Rakesh AV here, doctor from India, a neurosurgical resident. Please introduce yourself. Rakesh, welcome.
Thank you. Hello, everyone. First of all, wish you all a very happy new year. And I'm again very glad to be a part of this neuroanatomy series from a great neuroanatomist, Dr. Victor. I myself, Dr. Rakesh, I'm a neurosurgery resident from India.
Thank you. Nice to meet you.
Thank you.
Victor, we are ready for your presentation. Please proceed.
Yes, I'm ready.
It is okay. Dr. Hadi, I introduced you, so if there is anything you would like to add, you can always type in the chat box. Thank you.
Okay, do you see it?
Yes, we can see that.
Yes.
Yes, you can see?
Yes, yes.
Okay. Okay.
You must.
Yeah, we are going to talk about the surgical anatomy of this region. As you know, most of the lesions in this region are petroclival meningiomas, and they really present a challenge for neurosurgeons because of their deep-seated locations and proximity to critical neurovascular structures. So we are going to make a review about the surgical vascular and neural structures that we find in this kind of lesions in this region, the petroclival region. So do you see the cursor? Do you see the cursor? Yeah.
Rakesh,
yes,
can you
we can see the cursor. Nice.
Yes,
okay.
Yes, I can see the cursor.
Okay. Okay.
Nice improvement from last one.
Okay, here we have the supraclinoid carotid artery, left side and right side. Optic nerves, tear nerves, basilar artery, and the posterior communicating arteries. So the petroclival region involves this region, particularly this region. We can see in there the posterior cerebral artery, the third cranial nerve, the fourth cranial nerve, and another small arteries. In the pre-surgical preparation of the patient, we should know that we could find a special venous network. So I want to show you this video. Let me diminish the volume. Can you hear me?
Yes, we can hear you, and we can see the video. Thank you. We also see the cursor.
Okay, what's the reason I'm showing you this this video? You know, if you are going to make an approach, a transpetrous approach, you should know in a preoperative study, X-ray study, or vascular study. How do you have these small veins? This is the Labe vein, and you should know if this Labe venous has a good anastomosis with the Sylvian vein or another vein. For example, in this picture, you can see a very nice anastomosis between this Sylvian fissure and this Labe vein. So what could happen in this kind of approach? If you lesion this small vein, Labe vein, you could have a temporal infarct, a venous hemorrhage infarct, because you don't have a good anastomosis. But if you have a good anastomosis, like here, is the probability to have venous infarct is diminishes. So let's go to see this video again. It's a nice video. This is an injection of the venous system with silicone. This is the Labe venous. So Labe venous, Labe vein is located posteriorly in the almost in the temporal occipital junction. So this Labe vein has a very good anastomosis between the Sylvian vein and also the Trollard vein. So you can see in this brain, this brain doesn't have a good connection between those veins. So in the skull base, the Petroclival region is this. So here we have the sellar region, the posterior clinoid process, the third nerve, optic nerve, oculomotor nerve, the very, very small fourth nerve, the sixth nerve, and the trigeminal nerve. This is the Kawase approach. Maybe you note the difference between this region and this other region. Here we have an osseous tumor, an osteoma. This is a fissure in the postmortem case. So in this other skull base, we have the superior petrosal sinus and the inferior petrosal sinus. This is the sigmoid sinus and the transverse sinus. So sometimes also, if you are going to make the approach in the anterior petrosal approach or transpetrosal, you have to work with this superior petrosal sinus. Sometimes you can see a very small superior petrosal sinus, and other times you could have some problems with this superior petrosal sinus because they are of greater size. So this is the Kawase's triangle. So let's go to see this picture. This is a really nice picture because you can see a very nice anastomosis between the Sylvian vein with the Labe vein. In the transpetrosal approach, you cannot separate the temporal bone, the temporal lobe of the brain more than 1 centimeter. So you are going to work with a very small, space between the skull base and the temporal lobe. So if you displace the temporal lobe more than 1 centimeter, the risk of broke this vein is really high. So here we have another brain that was injected with blue color and red color for arteries and blue color for veins, and we have a very nice anastomosis between the Labe vein with the Sylvian vein. So in this picture, we can see the structures, the arterial, venous, and nerve elements that we have to work with. So, for example, here we have the supraclinoid carotid artery, the posterior communicating artery, and the posterior cerebral artery. This is the third cranial nerve, the oculomotor, and supracerebellar artery. This is the tip of the basilar artery. So maybe you have to work also with this cistern, the ambience cistern. So in this ambience cistern, you are going to find the trochlear nerve and the third cranial nerve. This is the superior cerebellar artery, and this is the posterior cerebral artery. Let's go to see this video. Look at this. I am retracting the temporal lobe in order to see the ambient cistern. So here we have the basilar of the tip of the basilar artery, the P1 of the right side, and P1 in the left side. They are really small. The posterior communicating artery that is coming from the supraclinoid carotid artery is greater than the P1. So this is a variant known as fetal variant. So let's go to see again. Look at this. This is the posterior communicating artery that is giving rise to the posterior cerebral artery, P1. And which nerve is this? Could you tell me which nerve is this?
Third nerve.
So, excuse me?
Third nerve.
This is the trochlear nerve. This one is the trochlear nerve. Is the smaller of the cranial nerves, and this is a third nerve. The third nerve always passes between the posterior cerebral artery and superior cerebellar artery. Always this nerve is passing between these arteries. So look at this. I am retracting the temporal lobe in order to see these structures. So let's go to see the posterior cerebral artery with some branches, and here we have special arteries that are giving rise the irrigation to the pineal gland. This is the mesencephalon, nigra substance nigra, and mammillary bodies, optic nerves, optic chiasm, and the posterior cerebral artery. This is known as the uncus of the temporal lobe. So here we have another brain, another specimen. We can see the trochlear, ocular motor nerves. So this third nerve is always goes between these arteries. This is the posterior cerebral artery, and this is known as the superior cerebellar artery. Yeah, you are right. And these small arteries are known as the posterior communicating arteries. As you can see, these arteries are smaller than the posterior cerebral artery. This is the most common presentation of these arteries. So in here we can see also the middle cerebral arteries, the other one, and these lenticulostriate arteries. So here we have the anterior communicating artery and A2, the anterior cerebral artery in the A2 segment, right and left. Which other structures can I see here? So do you recognize this small nerve? This is the fourth trochlear nerve. And let's go to see this nerve. This is the fourth cranial nerve, this one. The superior cerebral artery. Okay. In this kind of tumors, it's very important that you should to identify these these neural structures and the arteries. Let's go to see this video. I'm going to open the ambience cistern. Look at the fourth cranial nerve. The complications of this kind of surgery is the lesion of some cranial nerves. I think the fourth cranial nerve, because of its size, is one of the most damaged nerves in this kind of surgery. So, despite surgical advances and the usual benign history of lesions in this region, the incidence of permanent cranial nerve deficits has been shown to vary from 20 to almost 80% in a number of series. So, let's go to see this slide. This is really, really nice. First, we should recognize some structures in this size. So this is known as basilar artery.
Basilar artery.
Basilar artery. Okay. This is if we have in this region the third cranial nerve. This artery is known as posterior
cerebellar
cerebral artery. But then after this, we should identify some things in this variants. So this is the superior cerebellar artery, and this artery. What's the name of this artery? It's not common.
Ica.
That is pica, yeah.
No.
And
Anterior inferior.
cerebral.
No. This artery is very uncommon, and this artery was cut because this artery is going to the cavernous to the cavernous sinus. So this is known as trigeminal fetal persistent trigeminal artery. Have you heard about this artery?
Yeah.
This is
the most common persistent variant.
Yeah, it's very uncommon, but this is a persistent fetal trigeminal artery. So let's back to this region, the tip of the basilar artery. Here we have the posterior cerebral artery and the other posterior cerebral artery. Let's go to see what's happening in this. So here we have very small branches known as the mesencephalic arteries. So you were going to ask something. Excuse me.
Yes, Rakesh. Did you have some questions, Rakesh?
Yes. Sorry. Can you? Sorry to interrupt. Can you go to the previous slide, please, sir? Where is anterior inferior cerebellar artery in that? So is that missing over there, or
this one?
Anterior inferior cerebellar artery in this?
Yes, Ica. Where is Ica?
Ica. Ica.
Uh-huh.
So is it visible here, or?
Okay. Ica is this one, and Ica, yeah, could be one of these. But in other presentation, I want to show you some trigeminal arteries that I have found in this kind of brains. This brain has too many variants, as you can see in the basilar tip. This is a very uncommon presentation of this arterial network. So, then after we can talk about these variants of the the posterior cerebral arteries. So here we have the tip of this basilar artery, the superior cerebral artery, posterior cerebral artery, and let's go to see what will happen in this. This is a meningioma that is in very big. So this lesion occupies the anterior, middle, and some of the posterior fossal cranial. So here we have the Petroclival region, and in the surgery we should have many. You should have so many care in the removal of these kind of lesions. You should know that there are the arteries could be involved in these kind of lesions. So recently, most surgeons have tended to move away from radical resection to preservation of quality of life. Moreover, the availability of stereotactic radiosurgery has been associated with excellent tumor growth control and progression-free survival rates with a long-term follow-up. So in the surgery, you should take care with the arteries and nerves. So here I am resecting this giant lesion, and in the final of the removal, so here we have a very thin supraclinoid carotid artery with the anterior and middle arteries. So in here, you could see this supraclinoid carotid artery. Okay. And this is the pre and post-operative result. The rates of gross total resection vary widely from 20% to 85%. Reflecting differing philosophies in management and surgical aggressiveness of this kind of lesions. So we should take care with the remotion of these lesions, because we could have an important nerve or arterial lesion. So the quality of life is important for the patient. So here we have some horizontal cuts of the brain. Here in Mexico, I am working with some special staining of this kind of brain. So this is the Mulligan staining, in which you can stain the gray substance. The gray substance convert to a blue color. All what you can see in this slide in color blue is the gray substance, and the white is the same color. Gray substance and white substance. If you want to identify some structures, is much better to stain the brain. We can get this kind of result. So here we have a slide that shows the arteries related with the Petroclival region. So as you can see, here we have the superior cerebellar artery, the posterior cerebral artery, the tip of the basilar artery, the trigeminal nerve. This could be the fourth cranial nerve, this one, and the third cranial nerve is over here. I think this third cranial nerve was cut. So here we have the sixth cranial nerve. Trigeminal, fourth, the third cranial nerve could be this, yes, and it was cut very shortly. So here we have the mammillary bodies and the uncus of the temporal bone. Here we have another picture. This is the third cranial nerve, oculomotor nerves in both sides, the hypophysis, the infundibulum, the superior, the carotid arteries, optic nerves, the A2, A1 segment of the anterior cerebral artery, the anterior communicating artery, the tip of the basilar artery, superior cerebral arteries, and the uncus of the temporal lobes. So this is another nice, another beautiful picture. So could you tell me which structure we are seeing in here?
If I can see this well, it looks like
This is a gland. This is the pineal gland.
a pineal gland.
Pineal gland, yeah, it's really beautiful, and the artery that is giving rise, that is irrigating this pineal gland is the posterior choroidal, the medial posterior choroidal artery that is coming from the posterior cerebral artery. So this artery is really, really nice. I'm going to show you this yeah, this is the pineal gland, and these small arteries are coming from the posterior cerebral artery. This is known as the medial posterior choroidal artery. Okay. Okay, let's make an exercise. Here we have some arteries, and I'd like you to identify some of them. This is the
basilar artery.
Basilar artery, okay, right. This one?
Superior cerebellar artery.
Yes. Perfect.
Superior cerebellar artery.
Superior cerebellar artery. You can identify this because of the origin of the third cranial nerve. Inferiorly is the superior, and superiorly is the posterior cerebral artery. And which is this region?
Fourth
cranial nerve. And the mammillary bodies, this is the right third cranial nerve, the left third cranial nerve, and this one?
That is middle cerebral artery.
Middle cerebral artery, and these small arteries?
These are lenticulostriate.
Lenticulostriate. Yeah, really, okay, perfect. And here we have this structure is this is a part of the thalamus. The lateral genu body.
Okay.
Yeah. And if this is the geniculate lateral geniculate ganglion, this one, this artery is the anterior choroidal artery. Anterior choroidal artery. So this one is.
Okay. That is this what is it? Olfactory striate.
Olfactory striate. Yes. Okay. Right. Okay. This is the same view. So fourth cranial nerve, third cranial nerve. Excuse me.
Sorry to interrupt. Anterior choroidal artery is coming from. Can you show the? It's a branch of anterior choroidal artery.
Anterior choroidal artery is a branch from the supraclinoid carotid artery. The supraclinoid carotid artery is giving rise to three arteries. First one is the ophthalmic, and then the posterior communicating artery, and then the anterior choroidal artery.
Okay.
So here we have the optic nerve divides in the optic nerve, chiasma, and optic how you can say scintilla optica, the optic This is the
optic tract, maybe? Tract?
Optic tract, yes. The optic tract is going to this lateral geniculate
body. Okay.
No? Yeah?
LGB.
Okay.
LGB.
Let's see this. The optic tract and then the lateral geniculate body. So, okay. This is the cavernous sinus. So let's go to see some structures in here. Here we have the lateral aspect of the cavernous sinus, the optic nerve, the supraclinoid carotid artery, the anterior clinoidal process, third cranial nerve, fourth cranial nerve, here we have the inferolateral artery of the intracavernous carotid artery. This is the sixth cranial nerve. I am displacing in here the trigeminal nerve. Petrolingual ligament and the reverse ligament. This is the posterior clinoid process. Laterally, here we have the Kawas's triangle that was removed, and here we have the intrapetrous carotid segment. So in here we have the cochlea, the cochlear nerve, and here we have the semicircular channels. So I like you to see again this without voice to recognize these elements. Okay. Okay, this is the cochlear nerve. Semicircular channels, the superior, posterior, lateral. Here we have the middle ear with the ear ossicles. So let's try again. It's, okay. Can you see this?
We can.
Okay. Let's go again with this. So can you see it?
Yes, it was all right for me.
Okay.
Rakesh, can you see it? Okay,
Yes.
you can proceed.
Okay.
Yes.
Here we have the cochlea, the cochlear nerve, the semicircular channels, and the ear ossicles. Okay, let's go to see this another other video. So I put some plast in here in order to displace the cranial nerves. So I like you not pay attention with this. I think it's not the better. It's not the best to put this kind of plast to displace the nerve, but I didn't have other options when I did this dissection. So here we have the Ruber's ligament, the sixth cranial nerve, the Kawashi's triangle. In the Kawashi's triangle, here we have the intrapetrous segment of the carotid artery, and here we have the vestibulocochlear nerve and the facial nerve. Okay, let's go to see another picture. So here we have some elements of the cavernous sinus, third cranial nerve, fourth cranial nerve, fifth cranial nerve, and look at this. This is a really nice picture, because we can see the inferolateral artery of the cavernous carotid artery. So this small artery irrigates the cranial nerves. In here we have the meningohypophyseal trunk with the McConnell artery, with the this could be the hypophyseal inferior artery, the meningeal dorsal artery, and the posterior and the Bernasconi casinari arteries. Here we have the fourth arteries that are coming from the meningohypophyseal trunk. 1, 2, 3, and 4 small arteries. This is the venous in this region. So can you hear me?
Yes,
can you hear me?
Yes,
okay.
we can.
The meningohypophyseal trunk, the sixth cranial nerve. This is the sixth cranial nerve, and here we have the inferolateral artery of the cavernous carotid artery. So here we have the sixth, third. No, third is in the upper side. This is the fifth and sixth cranial nerves. So just remember that this triangle is known as the Parkinson's triangle. So let's go to see this other here we have the basilar tip of the tip of the basilar artery. Here we have the posterior cerebral artery. So look to this brain. We don't have a connection and anastomosis between the posterior cerebral artery and with P1. This is P1, and P1 is not giving rise to the posterior cerebral artery because this is a fetal variant of the posterior communicating artery. And here we have the superior cerebral artery, and in the left side we can see a P1, the left P1, superior cerebral artery, and the posterior communicating artery. This is not a common variant. This is a rare variant of the branches of the basilar artery. These arteries are the mesencephalic perforator arteries. So doing a dissection of the arteries of the brain, we could have some surprises. So as you can see in here, to understand this picture, you should recognize, first of all, the third cranial nerve. This is the third cranial nerve. So if this is the third cranial nerve, superior cerebellar artery. Okay, you are right. And if this is the superior cerebellar artery, this is the
basilar artery.
Basilar artery, right? Okay, and this is if this small artery, posterior communicating artery. Okay, perfect. So when I did this dissection, I saw this small artery, and I didn't pay attention to this artery. I didn't pay too much attention to this artery. I recognize this as a very small posterior communicating artery with a small fenestration. But look at this artery when I cut the brain. So it's really impressive what I found in this small artery. Look at this. This is the posterior communicating artery. This is the fenestration of this very, very small posterior communicating artery. And look at this. 1, 2, 3, 4, 5, 6, 7, 8, probably 9 arteries coming from this very small posterior communicating artery. Let's go to see again this artery. Okay, again, the basilar artery, right superior cerebral artery, left superior cerebral artery, P1 in the left side, P1 in the right side. This is the posterior cerebral artery coming from the supraclinoid carotid artery. So this artery is known as fetal variant of the posterior communicating artery. So this is P1. Okay, and then we are going to see this beautiful, very beautiful arteries that are coming from the posterior, from the P1, from P1. This is P1 in the right side. So look the branches of this artery, mesencephalic arteries, third cranial nerve, this and this. Okay, let's go to see this video. The tip of the basilar artery, superior cerebellar in the left side, in the right side. This is P1 in the left side and P1 in the right side. Look, these perforators arteries, the third cranial nerve, interpeduncular fossa, and the mammillary bodies. Let's go to see again this without sound. Okay. Is there any question? Is there any question?
Is there any question from the panel? You can ask questions now. Yes, Rakesh seems to
No, no.
unmute.
I'm just enjoying the lecture. Is it? I hope the lecture is still on or completed.
Okay, thank you. So I'm going to. Okay, hope you like it. Okay, can you hear me?
Yes, we can hear you, Dr. Victor. Amazing
Okay.
presentation once again.
No, thanks. Thanks again.
Indeed, we love the pictures. We just love the stunning pictures. Now I think it's a great competition to Rothon.
No, thank you so much.
So it's amazing. It's amazing. I really love your pictures.
Thank you very much.
And we hope to see many more of these, which is actually very needed and very basic for all the approaches. Thank you so much.
Thank you very much.
This is Dr. Perez. It was another great lecture. I think that this time you included more of neurosurgical images and some of the pearls of technique, which I really liked. So I think that, and also this quiz section was very good for us to kind of to exercise what we learned during your lecture. So I think this is a great addition in your series, and we hope that we will continue the next weekend as well, because you really, I think you are now, for now, really having a spree of lectures which are great and really viewed. We have lots of viewers online and here on the panel as well. So we're really thankful to you for your time. I would also like to say that we have another panelist here. It's Marco, who is part of the team for a long time. So maybe Marco, if you can introduce yourself.
Hi, everybody. My name is Marco Antonio. I'm from Bolivia. It was an excellent presentation.
Hello, Marco.
Hi, Rakesh. How are you?
Hello. Long time. I've been talking to you over Facebook. Nice to see you.
Thank you.
Yes, and Marco is also in Cochabamba, I think, Bolivia.
Yeah.
Dr. Perez mentioned that he's coming there for a symposium.
Yes, it is right. I'm from Cochabamba, Bolivia. Yes.
Mm-hmm.
Thank you.
Listen, this is going to be a neuroanatomy symposium, Dr. Perez.
No, we are going to have the Latin American Congress in the next year is going to be in Cochabamba, Bolivia. The Latin American Neurosurgical Society is going to organize this Congress.
This is a big event. Well,
yes.
It is.
I just wanted to know.
Mm-hmm. Yes, Rakesh, please.
Sorry.
Please, Rakesh.
I just wanted to know from Dr. Victor that do you know any conferences which just anatomy, I think you might be knowing, like just neuroanatomy conferences.
Excuse me again. I did not understand. Excuse me.
Any neuroanatomy conferences? The conference just dedicated to neuroanatomy?
No, I am going to participate in this TB neurosurgical studies. So I don't know how many times, but
okay.
what I can tell you is that I have too many specimens, too many specimens of spinal human cords and also brains. So I have found so many variants, anatomical variants, that I want to show you with videos, with photos, and everything. Yeah.
We would be glad to see everything of them.
Thank you so much.
Hope to see you more, sir. Thank you.
Yeah, I hope to see you too, Dr. Rakesh. Thanks for your comments.
Thank you. Thank you.
Yes, and again, if there are no more questions, then we can maybe conclude this session for today. We saw two great presentations from Professor Hernesniemi and one from Dr. Perez, which is really another strong one with lots of viewers. What I would like to emphasize, both online and here on the panel. And again, what can I say? Thank you so much, Professor Perez, for you and for your time. Even on the old year, depending on the time of the earth, you are working so to improve our knowledge, and we are really grateful to you. So we would like to wish you a happy new year with lots of success in it and lots of hangouts from all of us at Neurosurgical TV and from all around the world, because all around the world was listening to you. So thank you very much. Also, all of the panelists, and thank you so much for participating.
Thank you, Slavin, and I want you to also I like you to have a very happy new year. So we are going to work very hard this 2018 year.
Yes, thank you. We have also New Year wishes from Dr. Hadi, who had to go. He wrote, and also from Dr. Nguyen. So thank you so much. I think this concludes this year perfectly, and for me, it's already as it is, like it is New Year. So thank you so much. I'm so happy that this was the way to enter it. Okay, so we will stop broadcasting.